Hi class, this is Mary Cornell. We're talking about fluid and electrolytes again this semester. So if you're listening to this recording, it means that we had to cancel class for some reason. Now the class was going to be 4 hours long, so I'm hoping that we can do this in maybe four videos, or yeah, 4 videos, maybe 5. Um, and we're going to start with a review of what we talked about last semester. Okay, so let's talk about homeostasis and what that means. Um, to me, homeostasis means our body's ability to self-regulate and self-correct. In regards to fluid and electrolytes, our bodies are in a constant state of self-regulating. Um, Fluids are rushing in and out of between the capillaries, the interstitial spaces, and the um, body cells. Now, with fluid and electrolytes, there's a very narrow margin of what the body can tolerate, what's a normal range. Um, and if we go beyond or below or above what that range is, our bodies have all these mechanisms that come into play. So we're concerned about when our body mechanisms aren't working correctly or they're overwhelmed. Is really what we're concerned about when the imbalance is not being corrected on a regular basis. So I wanted to just give you a visual about what's happening here. We're talking about what's going on at the capillary bed. The arterial capillary bed is where water leaks out into the interstitial spaces and that bathes the cells, which I'm told the interstitial space is gel-like. It bathes the cells. The cells can take what it needs from the interstitial space. It's a little bit more discriminating and less permeable than the capillary walls, but it takes what it needs and discards the waste, and then the fluid gets back into the capillary at the venous capillary bed and takes it back up to the heart to get filtered or gotten rid of. I wanted to show you this picture. It's from a museum exhibit called Bodies Revealed. One of the exhibits was a skeleton with just the vascular system attached to it, and it was amazing. It looked like a fine fabric. The capillaries are tiny, thread-like tiny vessels that are so narrow that red blood cells have to line up one at a time to get through. And the walls are pretty thin of the capillaries. So you can, if you can imagine water, fluid leaking out and all that's dissolved, all the good stuff, the nutrients and oxygen and electrolytes that are dissolved in that fluid, leaking out into the interstitial space, which is gel-like, and bathing the cells, and the cells take what they need. It's pretty amazing. Okay. This is just to remind you, for adults, 60% of our body weight is water. Now, there are some variations. Women have less water than men. Muscle tissue holds more water. Fat tissue doesn't hold much water at all. Younger children have much higher content body weight of water. It's like 80%, and elderly are much less. Okay. This is just listing the functions of water in the body. I'm not going to go over them. But what I wanted you to know from this slide is that our daily minimal need of water is between 2 and 3,000 milliliters a day. And that 1 liter of water weighs 1 kilogram. So we weigh in pounds, so that's 2.2 pounds is what 1 liter of water weighs. Now, how does water get in and out of our body? So main way is by drinking. Also, food has water in it. There are some metabolic processes that the byproduct is water. If you have an IV, if you have tube feedings, if you receive an enema, retained enema fluid, retained irrigation fluid, these are all ways that we get water. How do we get rid of water? Urine is the main way. Our kidneys very much regulate how much water, keep a tight regulation of how much water we get rid of. Feces, we sweat, we lose water with breathing. If we've got something going on, if we're vomiting, if we have diarrhea, if we're on a ventilator, and depending on the rate of respirations, we can lose a lot of fluid that way. If there's drainage from body cavities, if you have a drain post-op or ileostomy, things like that. So let's pay attention over here. The minimum amount of urine that we should put out a day is 400 to 600 mLs. I was taught 30 mLs an hour, but that actually is a little bit more urine. So 400 to 600 is what they're saying a day is the minimum amount. If it's less than that, there's cause for concern. Okay, so we know how much we need to have in minimum. It's 2 to 3 liters. How much we need to have urine output is 4 to 6 milliliters. Okay, the mechanisms that we have to regulate fluid and water in our bodies. The kidneys have these JG cells on them that can sense when our fluid volume, blood volume is going down, and can also sense when there's a low sodium, and that triggers our kidneys to release renin, which stimulates this whole cascade of events to happen with angiotensin 1. I'm sure you've heard about this before. Enzyme that's secreted by the liver called angiotensin converter enzyme converts angiotensin 1 into angiotensin 2, and that stimulates aldosterone from the adrenal cortex. And aldosterone stimulates the kidney to reabsorb, to hold on to sodium, and to excrete potassium. And so then by that event, it would increase our blood osmolality, our serum osmolality. Now the hypothalamus is where our thirst mechanism is stimulated. So that regulates our water. And it also stimulates the release of antidiuretic hormone from the pituitary gland. Antidiuretic hormone, ADH, stimulates the kidneys to hold on to water and to concentrate the urine. Okay, so if you're holding on to water, you're putting more water back into the bloodstream, which would decrease the serum osmolality. Now the heart has sensors that sense when there's a high blood volume and high blood pressure, and that stimulates ANP and BNP, and it's atrial natriuretic peptide. And this inhibits ADH, so that means the kidneys would not hold on to water. It inhibits the renin release, so you would not hold on to sodium. So this causes an excretion of sodium in water to lower the blood volume. So it's the opposite of renin. It decreases serum osmolality. I left these in here in case you need to refresh your memory. Let's have a few questions to see how much you remember from last semester. If a large quantity of fluid has been lost from the vascular bed, what do you think will happen to the hydrostatic pressure? Do you remember hydrostatic pressure? This is essentially blood pressure in the capillary beds. Will blood pressure increase or decrease if you have fluid loss from the vascular bed? Pressure will decrease. If fluid moves from the interstitial space to the vascular bed, back into the blood, what would you expect when assessing the skin? Would you expect dry skin with poor turgor or edema? If fluid is moving out of the interstitial space into the vascular bed, you would expect dry skin with poor turgor. If a patient has a weight gain of 1 pound, approximately how many milliliters of water is being retained? So remember, 1 liter equals 1 kilogram. 1 liter of water equals 1 kilogram of weight. So if you gain a pound, that's half a liter, so that's 450 mLs. When planning care for stable adult patients, which oral intake is adequate to meet daily fluid needs? You remember how much is the minimum amount that we need to take in of water, fluid? It's C, 2 to 3 mLs, 2 to 3,000 mLs. You have a patient with a very high blood sugar and sugar in their urine. Would the urine output be increased or decreased? You would expect the urine to go up, would increase because your body's trying to flush out that glucose. What would happen to blood volume as a result? If you're getting rid of urine, it would decrease. What would happen to urine output? How would it change? Would it go up or down? It would increase. Why would the urine output change? Because glucose attracts water. That's going to pull, when you're getting rid of that glucose, it's going to pull water out too. So people can get dehydrated easy that are hypoglycemic. Okay, suppose you ate 3 bags of potato chips and your body functions are normal. What will happen now? So you dumped a bunch of sodium into your bloodstream, a bunch of salt. What would happen to thirst? You would expect it to be triggered. You would go up. Aldosterone, remember aldosterone triggers the kidneys to hold on to sodium, and you just dumped a bunch of sodium into your bloodstream. It would decrease. You would want to get rid of some of that sodium. ADH, that triggers the kidneys to hold on to water. Would you want to put more water? Yes, you would, because you've got a lot of sodium. You want to dilute it. What about urine? You would expect urine to go down, right? Because you want to dilute all that salt in your bloodstream. Your kidneys have been stimulated to hold on to water. Serum osmolality would go increase because you've just dumped a bunch of salt in your blood. If you decide to drink 4 gallons of water today, what would happen to thirst? If you just dumped 4 gallons of water, your thirst mechanism would decrease. What about your blood volume? That would increase. ADH, remember what ADH does? Stimulates the kidneys to hold on to water. Would you want to hold on to more water after drinking 4 gallons? No. You want to get rid of water. Renal blood volume. So your blood volume's going up. Your renal blood volume would also go up. Serum osmolality. Osmolality. It's how concentrated your blood is, the plasma part of your blood. If you drank water, it would dilute it, so it would go down. Urine output. Yeah, you would expect it to increase. Okay, that's all.